Today's article is about Pexaban versus warfarin in patient with atrial fibrillation. So the objective for this article was to determine whether Pexaban or warfarin are superior in preventing thromboembolism in patients with atrial fibrillation, and to show the long-term efficacy and decreased risk of bleeding as well as overall side effects. The trial design was randomized, double-blinded, and multi-center and comparative trial. It was performed based on whether the patients received warfarin previously or not. The duration for that was 1.8 years of follow-up. The study was performed in 1,034 centers in 39 countries. The inclusion for this article was that eligible patients had either atrial fibrillation or atrial flutter at the time of enrollment, or 2 or more episodes at least 2 weeks apart in a 12-month period. It was also eligible patients must also have at least one risk factor for stroke, which can include either age of 75 years old or greater, maybe a previous stroke or a transient ischemic attack, systemic embolism, systematic heart failure within the previous 3 months, or left ventricular ejection fraction of no more than 40%, diabetes, mellitus or hypertension requiring pharmacological treatment. Also, some of the exclusions were it can happen reversible atrial fibrillation. You can have moderate to severe mitral stenosis. Also, aspirin was a requirement with dose greater than 165 milligrams per day, or if you have stroke within 7 days. Some of the subjects about Apexaban and warfarin was that Apexaban is administered twice daily, with Apexaban given in 5 milligram doses. If the patient had had 2 or more of the following criteria, then you give 2.5 milligram. If, for example, he's more than 80 years old, or he weighs 60 kilograms or less. Or if his serum creatinine is 1.5 milligrams or greater. The subjective for warfarin was that it was administered as a 2 milligram tablet, and it's adjusted to an INR level of 2 to 3. If the patient was receiving a vitamin K antagonist prior to the study, they were told to discontinue the drug 3 days before the beginning of the study. Then warfarin was initiated when the INR goes down, or like when it's less than 2.0. The primary endpoint for warfarin and Pexaban was that the primary outcome was stroke or systemic embolism, based on the total events and the individual events. The secondary endpoint was that it could cause either death from stroke, myocardial infarction, or embolism. The population for Apexaban and warfarin was that the eligible patients had either atrial fibrillation or atrial flutter at the time of enrollment, or 2 or more episodes at least 2 weeks apart in a 12-month period. Also, the trial proved non-inferiority and superiority, and also 7.7 absolute reductions in the incidence of major bleeding in the Apexaban group versus the warfarin group. Overall, Apexaban reduced the risk of stroke or systemic embolism by 21%, major bleeding by 31%, and death by 11%. The statistical analysis was that the study's hypothesis indicated a 95% confidence interval of 1.88 for the relative risk of stroke or systemic embolism as compared to warfarin. And the primary and secondary analysis were performed using the Cox proportional hazards model. Some of the adverse events of Apexaban and warfarin was they can cause bleeding, swelling, or pain at injection site, could cause diarrhea, vomiting, and fever, or heavier than normal menstrual bleeding or bleeding between menstrual periods. The author's conclusion was that apixaban shows the same efficacy as warfarin in preventing stroke and systemic embolism in patients with atrial fibrillation, with a lower mortality rate and less bleeding as a side effect. Some of the strength about this article was that the study was well represented due to the large international population size. All study centers were encouraged to enroll a 40% or greater portion of patients who had not previously received warfarin. Also, assessment of bleeding was reliable based on ISTH, which is the International Society on Thrombosis and Hemostasis. Some of the weaknesses were there were no reversal agents for apixaban. The values of primary outcomes were only significant in reducing the risk of hemorrhagic stroke. The patient's follow-up was only 1.8 years. This does not provide statistics on the long-term side effects. The conclusion of this article was that use of apixaban versus warfarin in preventing stroke and systemic in patients with atrial fibrillation has shown to be as effective and less dangerous than using warfarin. The study shows with apixaban may even be more efficacious than warfarin and requires less laboratory monitoring, fewer drug interactions, and less incidence of major bleeding. The study used a constant sample population with certain criteria to ensure steady results. Overall, the study showed less patients' mortality with apixaban rather than warfarin.